Hello, my name is Timothy. Welcome again. Today, let's look at preeclampsia and eclampsia. As we know, preeclampsia is an hypertensive disorder that occurs after 20 weeks of pregnancy. So, when this actually condition occurs after 20 weeks of pregnancy, anything below there uh, should be considered as gestational hypertension at some point. But for it to be called a preeclampsia, it should occur anytime after 20 weeks of gestation until after delivery. So we have certain criteria for it to be categorized as preeclampsia. Here we have three main characteristics. We have hypertension, and this hypertension should be at least the measurement should be at least 140 over 90 millimeters of mercury, and the readings should be two readings at least 4 to 6 hours apart. The second one is proteinuria, and we have three either of the following: +1 in dipstick, or greater than +1 in dipstick, and above 300 milligrams in 24 hours of urine. We also have 0.3, greater than 0.3 of creatinine protein ratio. The other one is organ injury, which we will add here as edema, and this edema is usually of the face, eyes, you see, even including liver, brain, and we also have pulmonary edema. Those are the most common ones. And we have a number of risk factors, and the first one is actually family and personal history. If especially the first line family, either your sister, your mother has ever had preeclampsia, there are more chances of you having preeclampsia. We also have primary gravida. If you are if this is your first pregnancy, you have a high chances of having preeclampsia, because the body is adjusting, and the uterus is not roomy. It can press most of the organs, like blood vessels, and when it compresses, blood pressure increases, and this causes preeclampsia. We also have if you have a history of medical conditions like hypertension, diabetes, or a kidney injury, you have a high chances of you having preeclampsia. We also have obesity. We also have age below 18 and above, or above 35 is another factor. We also have multiple gestation, and this is brought about by the compression caused by these either twins or triplets that we are having here. Now let's look at pathophysiology of preeclampsia. This preeclampsia actually occurs due to faulty implantation of the placenta and abnormal development of the spiral arteries. The major player in this category is these spiral arteries. These are our spiral arteries, and under normal conditions, these spiral arteries should develop, and they should grow wide to increase blood supply to the placenta. And here we have the abnormal spiral arteries, and you can see on the right hand side we have the normal spiral arteries, which are wider, and thus it increases blood supply to the placenta. So what causes this preeclampsia is actually low blood supply to the placenta, ischemia, followed by ischemia and release of toxins by the this ischemic placenta or due to low blood supply. So when we have thin spiral arteries, which causes decreased blood supply, this causes ischemia, which at the end causes release of toxins by the placenta. And actually all this plays a role in preeclampsia. Now let's see what happens when we have when we have decreased blood supply. When we have decreased blood supply to the placenta, there will be ischemia and there will be release of toxins. Now these toxins are released. These are our blood vessel. This is our blood vessel. These are our blood vessels. Now, when toxins are released, the blood vessels, the the toxins actually will come and damage the inner lining of the blood vessels, which is called the endothelial cells. When these endothelial cells are damaged, they play two major roles actually. They regulate the tone of the blood vessel and also regulate the permeability. So when this is damaged, when the endothelial cells are damaged, we these two roles are impaired, and so this will bring about all the signs we saw previously. When they are damaged, the tone is impaired and the blood vessels will constrict. This will bring us to our first sign, which is hypertension. Because when blood vessels constrict, blood pressure increases. Now, permeability is impaired. When permeability is impaired, this actually causes more signs here. Proteins will escape. Proteins will escape and goes out of the circulatory system. And where proteins go, water follows. Where proteins go, water follows. We also know that proteins regulate the oncotic pressure, and this will cause edema. Now, when we have edema, we can have edema of the face, edema of the liver, and also the brain. So when we have cerebral edema, this will cause this one will cause cerebral irritability, which causes hyperreflexia. That's why we have deep tendon reflex as one of the tests we do to determine eclampsia at some point. When we have liver edema, we will have increased liver. Here also we have frontal headache. We will have frontal headache when we have cerebral edema. When we have liver edema, we will have increased liver enzymes like ALT and AST. Now, now, when uh, when endothelial cells are damaged, the brain will sense this. Will sense that there is a problem somewhere, and it will deploy blood platelets. This will cause increased coagulation or along the damaged areas, and all the blood vessels will be used with the platelets will be used up, and there will be decrease in platelets in the body. This is called DIC, because there is abnormal coagulation, there is excessive use of blood vessels, and this will explain the HELP syndrome, which is actually hemolysis, elevated liver enzymes, and low platelets in the body. So when the platelets is damaged, the endothelial cells are damaged, uh, we will have hemolysis, and this means that we've explained the HELP syndrome. The complications here are DIC. We also have premature delivery. We can have brain damage due to excess, due to high blood pressure. These are the common complications we have. Thank you for watching. My name is Timothy. See you.